Okay, let's get started. This topic will be cardiac arrhythmias. First, let's look a little bit at epidemiology. Cardiac arrhythmias occur more frequently in the elderly, people with a long history of smoking, patients with underlying ischemic heart disease, and patients taking certain drugs or have a variety of systemic diseases. The most common type of persistent arrhythmia is atrial fibrillation. A study of the prevalence of cardiac arrhythmias in general dental patients shows that 17.2% of patients may have some form of cardiac arrhythmias. More often than not, they're atrial fibrillation. The patient may not even know they have it, but 4% of those were serious, potentially life-threatening cardiac arrhythmias. So that means if you've got 1,000 patients in your practice, say 40 patients may have potentially life-threatening cardiac arrhythmias. An important thing to keep in mind is that, for all practical purposes, mechanically speaking, the heart is a pump. It's a pump with great servo mechanisms, but it's a pump. Along with a series of one-way valves, the heart, by squeezing down, pushes blood around the circulatory system. All heart muscle has an ability to spontaneously discharge and produce an electrical impulse that would spread to its neighbors. So that the discharges of the individual cardiac muscle cells are not chaotic, there is a pacemaker. There's an area of the heart called the sinoatrial node that basically sets the pace. Now, the spread of the action potential from cell to cell is rapid, but it's not rapid enough. Also, it would not do for the spread to begin at the top of the heart and then migrate slowly to the bottom of the heart. The entire ventricle must contract at once. To do this, cardiac contraction is controlled by a complex system of specialized excitatory and conductive neuronal circuitry, basically superhighways. Now, the action potential and electric discharge does spread circumferentially from the SA node through the atria, but again, there is the superhighway, the faster path of electrical discharge, which follows this pattern. From the sinus node via internodal pathways, the charge moves rapidly to the atrioventricular node, and from there to the main bundle of His, also called the AV bundle, and there down the left and right bundle branches, and from there subendocardially through the Purkinje network to the rest of the myocardia. All arrhythmias result from some form of disruption in the pattern of electrical conductivity or injury of the target cells, the myocardium. Signs and symptoms. The only clinical sign of an arrhythmia is a pulse that is too fast, too slow, or is irregular. You can't really depend only on symptoms to determine the seriousness of an arrhythmia. For example, PVCs, premature ventricular contractions, might be highly symptomatic, yet they may not be associated with an adverse outcome. Atrial fibrillation may have no symptoms at all, but patients may be at a significant risk for stroke. These patients are often on a, quote, blood thinner, unquote. Symptoms most commonly associated with cardiac arrhythmias include palpitations, that's often felt when a person is having the premature ventricular contractions, lightheadedness, feeling faint, syncope, and those related to congestive heart failure, shortness of breath, orthopnea. Most of that has to do with an inefficiency in the pumping action of the heart. Medical management of arrhythmias seriously or significantly depends on what condition the patient is in as a result of the arrhythmia. Often medications can be used. Frequently, in fact, medications are used. Sometimes the patient may need to be cardioverted. For example, when a patient comes into the emergency room with supraventricular tachycardia, sometimes they're cardioverted and shocked into normalcy. Pacemakers may be employed, for example, in a situation of chronic bradycardia. They may have pacemakers that are implanted cardioverters, defibrillators. Sometimes an invasive or cardiologist may try to burn a small hyper-irritable portion of the myocardium that may be triggering too quickly. That's done via, for example, radiofrequency catheter ablation. Or the patient may need surgery. Asymptomatic arrhythmias usually require no particular therapy, such as atrial fibrillation, with the exception of the high risk of these patients developing a mural or wall thrombus, which may break free, embolize, and cause an infarction of the brain or some other distant organ. Arrhythmias that are symptomatic, mildly so, are first attempted to be, the first line of treatment is medication. And patients who don't respond to the medications may need to be treated by some of the modalities we mentioned just a moment ago. Surgery sometimes is necessary for the treatment of patients with certain arrhythmias that are refractive to anything more conservative. Here's an interesting tidbit. Patients that have implanted defibrillators, at least in the past, used to be sensitive to certain electronic devices. I believe today most pacemakers or implanted devices are actually shielded, but at least for your information, and perhaps in some that exist now that might have some sensitivity to, in dentistry, using the ultrasonic bath cleaner, ultrasonic scalers, battery-operated curing lights, electrosurgery, anything that may generate an electromagnetic field may cause a problem for these patients. I would not ask you to memorize the classes of antiarrhythmic medications or the medications within those classes or how they function. There are two things, though, that you definitely should keep in mind. Number one, all of these medications work by affecting electroconductivity of the heart muscle. And number two, virtually all of these medications have some oral side effect, some oral manifestation that you will see as a sign, or the patient will report as a symptom. Let's look at some dental management. Now, patients with existing arrhythmias, whether they're diagnosed or undiagnosed, they are at an increased risk for adverse events in the dental environment. Stress, just the psychological stress associated with the dental treatment, or even the use of excessive amounts of epinephrine, may lead to a life-threatening cardiac arrhythmia in patients that are susceptible. Even patients that have their arrhythmias controlled using drugs or some other form, they may require special consideration when getting dental care. Now, the first step in risk assessment and in avoiding untoward events is to identify those patients that have a history of arrhythmias and those patients that perhaps have an arrhythmia that is undiagnosed. And you can do that by getting a good medical history, certainly including a pertinent review of systems, and taking vital signs. Check the pulse and rhythm. If you notice an arrhythmia and the patient had no idea, well, you just picked up an arrhythmia and you may in fact be saving that patient's life. Now, ultimately, it's your decision as to the risk involved in providing dental treatment, because you know the specific procedure you would do and what you would use on a patient that has a history of arrhythmia, and you have to decide whether the benefits of treatment outweigh any risk. What's the risk of no treatment? This usually requires a collaboration or consultation with a physician. You're not looking for permission. This is a collaboration. Indications to get a medical consultation with the treating, probably cardiologist, would be patients who report having arrhythmia or some other cardiovascular disease, or they suspect that they do, and they're not under the care of a physician. Patients with any irregular cardiac rhythm, even if they don't have symptoms, if it's new or not previously diagnosed. Patients, sometimes they just don't know what their diagnosis is, what their limitations are, and in those cases, it's probably a good idea to speak to their treating cardiologist or physician. If there's any questions or any uncertainties, a medical consultation should be sought regarding a patient's diagnosis and their current status, and to aid you in assessing risk for aggravating or precipitating a cardiac arrhythmia, stroke, MI, or whatever during dental treatment. Here's an interesting slide. The American College of Cardiology and the American Heart Association, they put together guidelines, and there's three categories. First is arrhythmias associated with major perioperative risk, and then intermediate perioperative risk, and minor perioperative risk. And if you'll notice that for the one with the high risk, major perioperative risk, you're counseled to avoid elective dental care. That kind of makes sense. These patients are unstable. Patients associated with intermediate perioperative risk would include patients that, for example, had a history of a myocardial infarction. They may have an abnormality on their ECG, but it may be stable. And arrhythmias associated with minor perioperative risk would include certain electrical anomalies, patients with atrial fibrillation. Again, there's a tremendous qualification. You're not expected to say, well, this patient has a left bundle branch block, so therefore they're a minor perioperative risk. When in doubt, seek a consultation. As dentists, we use medications that have a significant influence and associated risk in patients that have existing or undiagnosed arrhythmias. That is, we use vasoconstrictors, specifically, and for the most part, epinephrine, in our local anesthesia carpules. Now, low to intermediate risk category patients and those taking non-selective beta blockers like propranolol, they can be safely given up to 0.36 milligrams, which is contained in, for example, 2 cartridges of local anesthesia, relatively safely. Of course, you don't want to administer an intravascular injection. Vasoconstrictors should be avoided in patients taking digoxin because of a potential for inducing arrhythmias. Now, there's a bit of a qualification with the non-selective beta blockers. Patients who are taking non-selective beta blockers, when they get a significant dose of epinephrine, because the beta blocker prevents vasodilation, that will leave unopposed alpha vasoconstriction, and these patients can get a significant jump in their systolic pressure. It can be huge, with systolic pressures exceeding 200 milligrams of mercury. Now, patients at major risk for arrhythmias, if possible, vasoconstrictors should be avoided, and if it's necessary to use vasoconstrictors, it would probably be a good idea to consult with their physician. Small amounts of vasoconstrictor can usually be used in high-risk cardiac patients, especially if used as an infiltration and when accompanied by oxygen, sedation, nitroglycerin, good pain control. As mentioned in another module, gingival retraction cord impregnated with epinephrine should be avoided because of the associated rapid absorption of a high concentration of epinephrine and the potential for adverse cardiovascular and arrhythmic effects. Now, it probably should go without saying that reducing stress and anxiety in a cardiac patient would go a long way to mitigating risk. So, having the patient get comfortable with you, schedule short appointments, generally in the morning. People have better reserve. Make sure the patient is comfortable. Check vital signs before you start. If you are able to, or if it's appropriate, or if the patient wishes, it's not inappropriate, I should say, to administer an oral sedative. Nitrous oxide and oxygen is not contraindicated in these patients. It drops blood pressure to a small degree, and it has relaxation effects. Ensure good pain control, local anesthesia, and make sure postoperative pain control is in place. It does happen that these patients and patients that with significant risk require emergency care. So on the occasion that it's necessary to provide urgent care to a patient with a significant arrhythmia, and if treatment is necessary, it certainly is best done in a hospital setting. That's not always possible. Certainly what is done should be performed as conservatively as possible to solve the problem, or at least temporize the problem. Consultation with the patient's cardiologist or physician is probably a good idea, and management should be directed primarily towards pain relief, infection control, control of bleeding, basically palliative care. And that brings us to the end of the cardiac arrhythmias module of oral health care of patients with cardiovascular disease.